you for joining us today on this webinar hosted by BioLace MG. We're excited to have our special guest, Dr. Brad Labrecque, with us today. Dr. Brad has been doing this, has been using a laser for many, many years, has been doing this for a very good while, and he's helped many water lace users throughout the world, just going everywhere and just teaching people. So we'd like to thank him for doing this webinar. We're going to do something a little different. On the chat box, if you could please just put something there. Like the title says, I bought a laser, now what? What's your expectations on this webinar? Why did you purchase a laser? What are your reasons of purchasing it? Is it for certain techniques? You know, throw it out there on the chat box, and we'll be glad to answer a few questions. And we'll also do some Q&A after as well. So if anybody would like to just put something on there, I can read it out. If not, we can presume with our webinar. What do you think, Dr. Brad?
Yeah, it sounds a great idea. I mean, like you bought a laser. Now, what the heck do you do with it? I mean, I hear that so often along the way. I mean, so why did you get it? Obviously you got sold on it somehow and managed from there. So just a brief history. I did graduate probably about 43 years ago. Over time, I've had the lasers in my practice for over 32 years. They're not something new. They're something that I've grown up with. I've started it when it was early in fruition and just kept on learning and learning and learning. Like, if you've bought it, you got to learn it. And I spent, a career learning how to do it, how to be a master in this thing. Because remember, to be a master of anything, you have to put in at least 10,000 hours, right? I mean, it's just what it has to be done. So that was my goal at that sort of thing. Many years of practice, as you can see there. I've got, I had 5 full-time hygienists working with me, 3 doctors. I mean, we're a high-touch, high-tech office. I love technology. I think it's awesome. And pretty much anything that I do today, I never learned in dental school. How about you? Are you practicing the same way that you were taught at college? Chances are no. But we had to learn how to do different things at different times. Right now, I'm in Laguna Heights Dental, which is in California, Orange County, at that point. So if you bought the laser, are you using it daily? If you're not using it daily, that's terrible. I'm going to show you how you can pretty much use it for every procedure. Yeah, every procedure. It should be sitting beside you, turned on with you, right beside your control with your hand pieces to make it pick it up and use it somewhere along the way. Maybe you bought it because you kind of thought it was a pretty tool. Well, that's awesome. Maybe you bought it because your peers have it around the street and you figured, I need this to stay competitive, but it doesn't work for me. Well, why doesn't it work for you? It's been around forever. It does work. It's been proven to work extensively. It has great research behind it as well. But why doesn't it work for you? Or maybe your salesman was just really good. I mean, BioLace has had some pretty good salesmen over the years. So I'm not too sure which one it is, but you let me know along the way what it could be. So the agenda today is we're going to talk a little bit about lasers, like why they work. If you know what it can be used for, then you can kind of figure it out. And so the wavelength makes a bit of a difference. I'm not going to sit there and talk so much about wavelength like an early course, but I just want to touch on a couple of things. And then understanding settings. Okay, what makes a setting, what doesn't make a setting at that point in time? How safe are you to change that setting around? And then talking about protocols, give you some clinical examples and some ROI and some billing suggestions that I do in my practice with our group. Okay, so in the digital world, which we live in now, we have cone beams. How many of you have a cone beam? How many of you have taken enough courses to understand what you're looking at? Or have you just kind of taken a little bit to know, I use it for placing an implant? Okay, I just want to use it because I want to show the patient their whole head and stuff like that. So how much training did you take in them to make it work? Intraoral pictures, we all do that. I mean, it's something that's pretty standard. Digital radiographs, yes. Intraoral scanning, majority of people do that. Was it easy for you to learn how to scan? Are you using your scan on every patient? Like in our clinic, we take a scan on every patient. It is part of our exam and making it happen. And then from there, we decide what we have to do. We mill, we print. Do you? It took some training to learn how to do that. And then, are you using AI technology? Two of the major ones on the that we're doing now is Pearl and Overjet. And so then, if you're using AI to help diagnose at an earlier stage, you have to change the tool. And then a handpiece with a piece of stainless steel might not be the best thing. And then from there, perimetrics. Yeah, maybe you haven't heard about that and stuff. It is a tool that is a vertical crack detection. So we can use it if somebody has a sore tooth and you can't see anything going on, or if they're grinding their teeth and they say their teeth are sensitive. Now you have a tool to put a baseline on where their tooth looks like by just a small little tap on the tooth, and it gives us a reading. So these are things that we have available to us. And so if we're using so much on the digital world, goodness gracious, we got to have to start thinking about how we're going to change our treatment protocols, because lasers, AI, robotics, they involve more training. Okay. I mean, it's important. I mean, then we have the fight. Well, insurance doesn't pay for it. Does insurance have to pay for everything that you do in your practice? Is there a cost to it? Yes, there's a cost. There is a cost, but can you make it work for you? You can make it in time savings. You can make it in more procedures that you wouldn't necessarily do. I can't see anybody wanting to do a frenectomy with a scalpel blade and having to suture it up. It's just a bloody mess. I want to treat it with something like a laser because it doesn't bleed. I can see my fibers and take care of everything. So anyhow, dentists, we're selective in what we do, but our adoption needs to help us benefit the patient and in practice growth. So over my time, I've always looked at it going, will this tool make it better for my practice? Practice for me? Will it be better for my patient? And will it be better for my end clinical result? And so Basil always said, you need to change the hammer if the nail has changed. And our nail has changed over the years. What you've learned in school, what you've learned over the years takes a back seat, basically. Our basic foundations are the same, but now we have different treatment protocols to get the job done. And that's kind of where we're going to go with this. So we can treat it. We don't have to say, let's watch it anymore. Caries, if you're using AI to help diagnose caries, you're seeing it when it's like 10, 20, 30% indented. You want to take a 5.56 burr to that poor little old tooth at that time and create more microfractures than necessary? No, then you might as well let it get bigger, because then you're not going to damage the tooth. So tools need to change because of these sort of things. And so you got to understand, you got to get trained to be efficient with the new paradigms. And if your practice is having trouble with it, is that sort of thing, then is it the tool or is it the person holding the tool that's the problem? All right. More often than not, I get doctors saying, "Oh, I'm working with this, and it's not working fast enough. I got bleeding on the tissues and all those sort of things." I hear so many times. It all boils down to improper use of the handpiece on the tissue. You're trying to use it the wrong way. And so we'll talk a little bit about that. But at the end of it all, I mean, in diagnosis of caries, all these tools are available to us, and so many people are using, we were using Pearl at the time right now, but we can identify this. Now, with AI will say, hey, you got to have something going on there. You can't see that with a digital x-ray. But now the decision is, do I treat that? If you want to treat it, again, a 5.56 burr is probably not the best thing. So not only does Pearl help me in what I want to do, and I'm only bringing Pearl up, it's something that I like. There's other ones as well. Whatever you decide to get is great, but it helps pick up periapical lesions, caries, periopocketing, pocketing, bone loss, at the like. And so it's a very good tool that we can use now to submission for into insurance. And I also use it for when you show like that bottom slide where you see that where the tissues are. I mean, the caries is so noticeable that, again, the patient has a good visual of what's happening, and they kind of buy in pretty easy. So if we're going to treat the pathology easier, early detection is all what we're talking about. So we want to treat sooner in restorative. Why? Because we can see and identify decay sooner. So will a burr be the best tool at that point? In periodontal therapy, how much bone has to be lost before you treat it? 1 millimeter, 2 millimeters, 3 millimeters, 4? How long do you need? Should you wait? Well, if you're starting to see bone loss in a certain area, we're going to try to turn around and stop the progression of the disease earlier. But is the way that we've been taught to raise a flap, is that the best way now? We have tools with your laser that you don't have to lay a flap. You can do it flapless. And then you can turn around and stimulate bone generation. In endodontics, if you're doing endo, how much bacteria is left traditional therapy? 50 to 60%. Are you happy doing a procedure leaving that much bacterial levels behind? We can remove 99.8% with your water lace. And we can do crown lengthening in a single visit in conjunction with prepping. And peri-implantitis. Oh my goodness. We are using a new tool to restore people and retrieve. And how do you clean an implant with any tool out there today? The only tool that you can use is laser light therapy. That's it. It's the only tool that's going to make a difference in your life and then for your patient's life. Because we see so many, I mean, not everybody looks after their implants, even after they spend the money for it. So over my years of practice, I just kept on adding on what would make sense to be a successful practice. But did I buy it and then turn around and try and learn it on with folders and instruction manuals and now YouTube? No, I took hands-on courses, and I had took courses over my years to learn how this darn thing worked, because I had multiple lasers in my practice, and I needed to know how they work. Because if you know how to make them work, life is good. All right. Why do I do it? It makes my dental procedures more predictable, keeps my schedule under control. I can do more procedures per unit at a time. I can increase my practice revenue, which I consistently have done over my years, and I improve my end result. And you know what? I like these people. These people give me great Google reviews. I want good Google reviews because I want to grow my practice. All right. I want to make sure they're comfortable. I want to be wowed when they come into the practice and say, wow, all this technology. And Dr. Brad was able to repair my tooth simply. He saw a problem. He saw a crack. He said, recommended a crown. We fixed it that day. He milled it the same day, put it on, and he was able to get a good picture of it, even though my gums were damaged. Wow, that's kind of what I want to hear. So, as successful, I would love to help you be very successful. I want all of you to grow and be successful as I've been with my technologies. But I never really asked what was in it for me. I always ask what is in it to make it better for my patients. And I think that's the way we look. And if that's the case, then we can change the hammer on that. Because dentistry hasn't changed. They still use these same textbooks today that a lot of you took, if they use textbooks at all anymore, right? But Pathways to the Pulp, it was still the textbook that I studied endo on 43 years ago. And it's still the basics of endo right now. That's crazy. Okay, so our disease process has changed so much. So the laser light, okay, then this is what you have to do. You have to look at a procedure and you have to understand what this laser does. So let me talk about that. It removes the smear layer. You can use it instead of blue etch. If you're doing, and then it cleans the smear layer and the biofilm off the root surface. It prevents marginal leakage on bonded restorations. If you clean the restoration with a laser on bond prep prior to cementation, you have a stronger bond. And research has shown that laser interaction on the surface of the tooth at that marginal on that marginal margination of the filling that you're doing or the crown will prevent future leakage. It stimulates reparative dentin. Why? We'll get into that, why that happens. It's bactericidal. Everywhere you pick it up, you're removing bacteria, which helps remove the possibility of sensitivity. Let's say in a restoration, it gives you a cleaner feel. Okay, we use it. You can use it to place an implant, to help you place an implant. And it's great as a bactericidal in doing endodontics. You don't have to use sodium hypochlorite and EDTA. It stimulates fibroblast reattachment. It stimulates fibroblast growth by 50% compared to traditional. It stimulates bone repair and it stimulates bone growth in certain situations. You're using it now for mild to moderate periodontal disease, 4 to 5, 6 millimeter pockets. You can regenerate some bone around that and even a failing implant. It provides hemostasis. You can do frenectomies without bleeding. You can never have to pack a cord and improve your scanning because you'll see your margins much clearer. You do not have to double pack a cord and cause some fibroblast problems at that stage. You can completely clean implant surface. It removes it removes calculus in deep pockets with no flap, 5, 6, up to 7 millimeters. And it reduces inflammation. So if you use it to clean out an extraction site after you're done to remove any fragments and any infection that might be in that area, then it reduces the inflammatory response and stimulates some bleeding at the same time as you're cleaning the bone so that you'll have quicker resolution of that problem as well. So these things happen. So I don't necessarily have to use acid etched sodium hypochlorite, citric acid, arrested, or tray traction cords. The laser is my scalpel, and EDTA, even Gluma. I mean, Gluma is very caustic. Where else would you use Gluma in the body? Acid etch at 35% phosphoric acid. Where else would you put that on the body? No wonder we get sensitivity. And then we have to throw something else on that's just as bad to stop the sensitivity. So think about it. If we can avoid some of these tools as the way, and we have a tool that can replace that, that's a better way to go. So if you're looking at the laser, just remember it's in the infrared zone, okay? I mean, you all know that the light that you see is a neon light, and it's just your guide to see where you're going. And we're working in the erbium range over here with the water lasers, and it is a 2780 nanometers at that point in time, all right? And so in doing that, we know that the light energy, when it's absorbed by the tissue, again, every time you pick it up, is anti-inflammatory, it's antibacterial, it stimulates ATP production, so it improves tissue healing. And you hear so much about ATP production these days. They help anti-aging. And it stimulates cell growth of fibroblasts, osteoblasts, and collagen. Again, this is what laser light does. And so nothing that ahead of time does this better than laser light. So lasers are absorbed either by pigment, and which is hemoglobin, or water and hydroxyapatite. There's two different styles of it, right? So the pigment, hemoglobin, those are your diode lasers. They're soft tissue lasers only. You can't use them on bone. You can't use them on tooth. It always works with heat when you're using it for surgery. It kind of heats the tissue up with the pigment, kind of melts it away. And it's a great tool for hygiene. If you're not having your hygienist using this on a daily basis, you're missing out, okay? Because the laser bacteria reduction removes some of the bacteria, so you don't have to use Arrestin. And at the same time, we can also, that photobiomodulation effects help stimulate new cell growth after some surgeries as well. In this case here, here's a hemangioma, very large. And my choice for this lady was, should I cut it off? If I cut it off, I'd use my water laser. Or because it's so heavily pigmented with the blood, maybe I can seal up the blood vessels. So I picked the diode laser for this. Now, this is pretty extreme, this one. The smaller ones remove very, very quickly. This was heard a month. All I did is shine the laser energy on that lesion for 3 to 4 minutes at a certain wavelength, which was my 940 nanometer wavelength. And I had it turned up to about 3 to 4 watts. Now, I gave some anesthesia for this because because the wattage was quite high, but I needed deep penetration. But the takeaway from this is I didn't have to touch her. And this is what she looked like in a month. Amazing, right? The managed from there. So we could charge for removal of a hemangioma. Now, the Waterlays works with water and hydroxyapatite. It's called a Waterlays for a reason, because it looks for water. That wavelength needs water to work. Once it finds the water, it causes the water molecules to expand. Once they expand, they kind of expand thermally. So they create a little bit of heat, but they also are explosive and breaks down the tissue around it. So it helps vaporize the tissues. All right, at that point. So anything that has higher water content can be used compared to something that doesn't. If it doesn't have a high water content, we have to apply the water to make it work. So think about it. If you have infected tissue, it has a higher water content. So the Waterlays would be an ideal situation. If I have caries, it has a higher water. So it's going to remove carious lesions quicker and faster than the enamel and dentin. It's going to remove granulation tissue in a pocket. It's going to remove calculus faster off the tooth as well. Okay, and manage from there. So again, it looks for the hydration to make it work. So we can make that work as well. So if I'm taking off a veneer, it is looking for the hydrated layer. Where is that hydrated layer? Not in the veneer, not in the porcelain or wherever you use, but it's in the bond. You can see as it's moving, you can start seeing changes underneath the veneer. It is breaking down the cement layer. It isn't going into the pulp. It isn't cutting the tooth. It stops in that zone at that point. So the removal of veneer is very successful and very quick. Now, in this case here, I'm using a higher power because I don't care. I'm not putting it back on again. I'm replacing these veneers for this patient. So I've lost a little bit already because of the exposed technique. And then I just pick the rest off with a scalpel bit. I mean, a shepherd's hook. So again, quick and easy. And this is real time, didn't speed it up at all. Okay. Now, at the same time, I'm doing a class 2 here, which is just through into the dentin. So probably about 25-30% into dentin. And I am moving back and forth on the marginal ridge. And if you observe in the mirror that I'm breaking through that marginal ridge very quickly, hey, there's some benefits here. The energy only comes out of the end of the tip. I can rest the side of the tip on the adjacent tooth and not cause any damage. Can you do that with a real reverb? No. Hey, I got another one for you. I can sit down with the patient and get this done within a few minutes of the patient sitting because I don't need any anesthesia for this. Why? I'm not aiming at the pulp. I'm going interproximally. It's not sensitive. And so now once I identify where the decay is, I can start to remove it very quickly and easily and save as much natural tooth and healthy tooth as possible. So won't into it, watch the whole thing, but it's quick. You go, is it as fast as a high speed? No. But how about my chair time? Chair time is more of a necessary to discuss over speed of the procedure. Because if I can get somebody in and out of the chair quickly and easily, that's where I make my money. Do you know how much it costs to sit a patient in a chair? It's been looked at many, many times. But Henry Schein did a study a few years back, and they said it was about $285 to have a patient sit down in your chair on an average basis, just to say hi. Right. So again, if we can do more things in that period of time when the patient's there and quicker and get them out, that makes more sense to me. So wavelength does matter. It all depends on what you want to do it for. So ideally, look at your procedures that you're doing. How can the laser help me make this procedure go good? And then use it. The more you use it, the better you will get. All right. Again, with wavelength, we can see that when you look at the erbium 2780 and we compare it to the 2940, they're both absorbed 100% the same by hydroxyapatite. That's the yellow line. Now, water is a bit of a difference. Our water laze isn't absorbed 100% by water. Huge, huge, huge advantage because we are creating a little bit of thermal interaction. That thermal interaction helps us get hemostasis. If we didn't have thermal interaction and it was absorbed 100% by water, as you cut through, it'll bleed. And so then you have to reduce the water or switch to a diode laser or an Nd:Ag laser to turn around and stop the bleeding. Well, now you're stuck with two lasers at that stage. With the beauty of the water laser, and you can pat yourself in the back that you made the right choice, is because with soft tissue, the water laser heads over heel better than any other laser on the market. All right. So the whole idea is to work smarter and not harder. So water laser interacts with water, creates minimal heat. It looks for water. The light has to do the work, not the tip. So most times you're not touching the tissue that you want to have an effectiveness. It mainly works non-contact. Yes, certain ideas, sometimes we touch the tissue a little bit at this stage, but you need to control your hand movements. And this is where a lot of doctors fail. They go, oh, I try working with this thing and it just doesn't work. It's giving me problems. And then we sit down and we kind of go over it, and they come into the office and I start with saying, okay, let's get some procedures together and let's figure it out. And then they say, well, this is where I caused my problem and it doesn't work. And I go 9 times out of 10, you're trying to make the handpiece work like a high-speed handpiece or a low-speed handpiece, but not a laser handpiece. And that's where we need to pick it up on and manage it from there. So that's what you need to learn. So just to give you an idea, this is what I use my laser for. Frenectomies, pigmentation removal, gingival troughing, fibroma removal, soft tissue recontouring, pre-prosthetic surgery, implant exposures, cold sores, aphthous ulcer treatments, extractions, crown lengthening, restorative, pulp capping, veneering, crown removal, pediatric procedures, endo, grafting, root resection, dry socket treatment, cyst removal, post-surgical osseous conditioning, periodontal therapy, mild to moderate, and periimplantitis. What procedures did I leave out? All right, because at that point in time, I've learned that it has an advantage everywhere we work with it. Okay, once we figured out what the procedure, how we want it to work on that procedure, then from there we can decide if we need to charge for it or not, or can we charge for it? And that's the big part. So will the tool make it better? I think so. But if you can't answer how it would make it better, you need more training. You should be able to understand what this laser does, which I talked a little bit earlier in the webinar. Manage from there. If you can't answer quickly why this laser, the wavelength will help you in your procedure, then you need to have more information in your head, and you need to get some more training at that point in time, because training will make you better. Okay, so let's talk about perio. If we compare perio here, is that it is traditionally, who wants to have a flap? We have to carve bone away. We expose roots. It's fine. It's painful. It's like, you can't put the bone back. You're doing root shortening, crown lengthening, exposing root surfaces, and the patient is saying, hey, my teeth are more sensitive now than they were. Why did we do this? And if you practice long enough, you'll understand that that happens, right? But if we can not do no flap, so goodness gracious, if most of you are in the GP right now, you have the opportunity to see periodontal disease as soon as you can. At that point, you have a hygiene in your practice, or maybe you don't have a hygiene in your practice. Maybe you're doing it yourself. But you can see that patient on a regular basis now to see if the therapies you're doing are working. But if you're starting to from one probing to the next and you are getting deeper, whatever you're doing ain't working, then you got to turn around and figure out how to do a different tool to make it work. And the water laser is your answer. Okay, now you can turn around and remove any calculus that might be burnished on that you can't feel. It's going to stimulate bone growth. All right, we're going to maintain root coverage. It's less painful than traditional. I'm not saying it's no pain, but it's less painful. And there's no irreversible damage because we're not removing bone, we're stimulating bone growth. So again, you can do pockets instead of whole quadrants, and that's at the same time, same fee, less chair time, and a happier patient at the end of it all. So that's important, okay? Because nobody wants that. I'm quite sure of it. But I don't think anybody would want to go for flap surgery. Am I correct? So it's inflammatory, it's traumatic, it removes bone, it's not going to grow back. You recontour bone. As soon as you open it up, you're already losing a millimeter of bone. It's not a sterile surgical site, right? Water laser, remember, when we pick it up, it's keeping everything clean and bactericidal. And it's a long period of time to heal compared to more advanced techniques with our laser. So phase one, I'll just bring up this, is that, we're focusing on water lasers, but, when we're doing perio, this is phase one. If you have bleeding on probing, you have bone loss starting, you have areas that have increased in probing depth, something's not going right. So this tool used by your hygienist and doing a procedure called laser bacterial reduction, first of all, will reduce inflammation, will help reduce bleeding. It'll remove the infected tissues from the pocket and promote healing. It doesn't remove calculus at that point in time, but it does remove granulation tissue, which is in the pocket, and you have a more effective removal of granulation tissues compared to curettage. So gingival curettage just scrapes it away. This actually picks it up faster because it is pigmented. And so it's going to work better. So when that happens and you're moving along, and here I have the lane Amy being turned up really high, I have to move in a range of about 5 seconds on the buckle from distal to medial. That's the speed you want to work with. You don't want to go fast because the laser energy needs to be absorbed by the bacteria, which are pigmented, kill them off. And so you can't do it. Think of putting your hands through a candle flame. If you move it back and forth really fast, it doesn't get hot. Then just hold it and move it slowly, and you start to feel the burning. This is with an uninitiated tip, so there's no pain. And it takes about 5 minutes to do an adult mouth. 5 minutes. Your hygienist can't complain too much. So we always do that at the very beginning. If you have bleeding on probing, and we do that before SRP. Why? Well, it makes sense. I mean, before SRP, you're going to try killing the bacteria because when you start digging in there, you're spreading the bacteria all over the place. So then at that point in time, if you have any concerns about pocketing and inflammation, you can bring them back in about 6 weeks and see how they're doing. If there's pockets that are failing and not getting that better, we have to consider a different tool. If we're going to consider a different tool, it probably will be the water laser. Why? Because there's probably either calculus left behind, the pocket was too deep, and so at that point, we have to remove granulation tissue deeper into the pocket. And then we also probably have bone loss about 5 millimeters or so, and we want to regenerate some bone coming back in. So that's the process where we go. So again, last bacterial reduction, yes, done before SRP. Bang. All right. I like doing it at 0.8 watts continuous wave with a 400 micron fiber. It is uninitiated. Okay. I like continuous wave at 0.8 watts because it doesn't initiate in the pocket. Some other settings on the lasers can help that they recommend will start to initiate if they have too much blood. That's not good. This doesn't. All right. So then we bill the patient for LBR, and we bill them for LAPT. Hygiene has said, hey, we're doing laser-assisted periodontal therapy with a laser. It's removal of granulation tissue, and that's it. So insurances don't really cover all that. We have to do a bit of an add-on to that to make it happen. But does it make sense? I mean, I have practices that I work with and stuff. They charge anywhere between $85 to $200 to do Laser bacterial reduction, it takes 5 minutes. So at that point in time, if you look at the return on your investment, if you saw at $85, which is a pretty common fee because what some people charge $75 per pocket for Arrestin. Okay, insurance doesn't cover that either, but nobody complains about using Arrestin. But how do you know, how am I going to talk to my patients? We talk to our patients all the time that they have bacteria, that they're losing bone. And at this point in time, you need to get that under control, and brushing and flossing doesn't way the only way to do it is you have bad bacteria in your mouth. They're causing a big problem. We got to kill them all off. If we kill them off enough times, they will not come back. Quick and easy. Oh, I understand now. All right, keep it simple. But here we go. Just under $600 for 7 patients per production for over a period of time, about 16 months, 16 days, pardon me. You could get about $9,500. Now, you might not get that in a month. All right. Let's say your hygiene department does it a couple one day and a couple another day. But by the time you hit 41 patients, you have billed out an extra $9,500 for production. That's pretty impressive, considering that the laser doesn't cost that much, as far as I know. Right? The matters from there. So, average time, if you only charge $55, you'll make $6,100. So, pick the fee that you feel comfortable with. And that little laser thing, just by doing laser bacteria reduction will certainly pay for itself in 2 to 3 months. Easy to do. Again, training needs to be done with the hygiene department, so they do it fast enough to get the results that we want. But training is important at that stage as well. All right, and if you combine that with SRP and curettage, which is laser assisted periodontal therapy, it works about $50 a quad. 3 patients per day, that could be an extra $600. So you get another $9,600, let's say, in 16 days. And that improves your standard of care. You're removing infected tissue, which you're already doing during SRP, but you're using another tool to help it be more effective and more cleaner. And you're stimulating healing of the tissue, healing of the fibroblasts. And sometimes just with that, you're stimulating a bit of bone regeneration as well. So you're getting a lot. The patient's getting a lot for that $50 a quad. If we turn around and put it together, your hygiene production with a diode laser is phenomenal. And if you're not doing it now, you need to think about doing it and need to pick up the protocols to figure out how to do it the proper way. All right. Phase 2 now is that when this doesn't work, you still have bleeding and probing in a pocket after you've done initial therapy. You got to come up with a different tool. All right. So we have to come up with the waterlace tool, because it now can go deep into the pocket without raising the flap. As you do that, you'll start to see calculus flying out of this pocket. This is after SRP. We're going down about 7 mils on this pocket, down to bone. And what we're doing is cleaning the root surface, removing any tissue that might still be infected on the inner wall, stimulating some bone regeneration by stimulating some bleeding on the bone, and cleaning the bone at the same time. This is less invasive, it's more comfortable to the patient, and it's quicker care time. You do that, everybody gets excited. So you have situations where you're starting to see patients losing some bone early, fix it. That is 6 months post-op. You start to see bone regeneration on x-rays within 6 months, and it doesn't go away. Here's a class 1 furcation. And again, 6 months, it's filled in. These are amazing. I have doctors that have just picked this up to treat class 1 furcations on a regular basis. And they bill for it. Bill for the procedure. Okay, you're doing osseous therapy at that stage. How do you bill for it? Well, laser bacteria reduction doesn't have a code. Okay, so we put down LBR on a coding sheet. That's at $85. SRP with laser, well, SRP is it has D4340. Laser degranulation, we place that in at that point in time. And we also we'll do laser irrigation at a different rate for $75 a quad. We do osteosurgery at 4261. We're only usually dealing with a pocket here and a pocket there. Again, that's a billable procedure at about $694. And or we do some soft tissue removal. I put a distal wedge here. Again, use your erbium laser over that because it's quicker and faster as well. But again, perio is probably underutilized in your practices today. And I think you can really make a huge difference. Take some time to learn it, how to do it properly, and be successful. Periimplantitis, I mean, Albert used to say, the world we live in today cannot be solved with the same thinking we thought when we created them. And I put periimplantitis there because we have a titanium post that has bacteria that can build up on it. And how are we supposed to clean it? New technology needs new tools. Case of mine, this is a bridge that we had placed. We started to see some failures around the bridge. We were starting to lose bone in that zone. We treated it with the erbium laser. This is a 9-month post-op. No flap, just no graft, just cleaning the surface and cleaning the bone and stimulating regeneration. That's all we did. Nothing more than that. All right. Another case from a good friend of mine in San Francisco. Again, great success on this one. All right. And at that point in time, we can do laser bacterial reduction around an implant. In fact, if there's any bleeding at all around an implant, you should do laser bacterial reduction. Any mucositis at all, we tell our patients that. In fact, we tell our patients initially upon placement that, hey, we are going to bring you back to keep things under control every 3 months. You're going to be in our perio program. And then once we see that it's well maintained, we might let you out. Okay. But if we have to do a decontamination, degranulation of tissue and clean the implant, we charge 325%. Just to give you an idea. Again, there's no code for that, but we have to discuss that with the patients as well. All right. Endodontics. If you're doing endo, goodness gracious, you're leaving 50% of the bacteria behind. Are you happy with that? It's going to be, what's going to happen is going to be the standard of care. Erbium lasers are slowly moving up the scale in the standard of care to be the standard of care. And if you're not using an erbium laser, you shouldn't be doing endo at all. Way back when, we're talking like 40 years ago when I was in college, Apex locators first came out, and they were thought of by the endodontic community as the worst thing ever. Would you do endo without an Apex locator anymore? You'd be thrown in the bus so fast, right? So again, technology changes. More endodontists are using erbium lasers now than ever. Okay, I mean, a few of them are still using the stone endo, which kind of is sodium hypochlorite being flushed around under a bit of pressure, but the majority of people are dropping that and moving into this. I mean, you reduce post-op pain. You're reducing inflammation. That's what lasers do. Minimal canal opening. I mean, maximum I go is 25. Opens all the lateral canals. And laser energy is not only absorbed in the canal, but it's also in the lateral tubules. But the laser energy also gets out to the PDL and starts breaking down any bacteria in that zone as well, because the light gets there without causing any breakdown of the tissue in the zone. And if there's an apical lesion as well, it starts breaking down the issues there as well. So it's more than just scooping it out from the canal at this point in time. Energy spreads itself out to be successful. And then this case here, the case was being prepared, and this was working with an endodontist, and then this is prior. Say, let's put the laser in now before you obturate. Watch what happens. You always start to see this slurry of material coming out. Okay, and so what do you do with that? Well, goodness gracious, that means that's everything that you left behind. That's your smear layer. That's opening up the lateral canals. I mean, it's doing so much more for you. So we never do endo without a laser. All right. So we use, at that point in time, we use laser canal debridement. We charge $225 to pick up the laser. We do, if there's an obstruction in the zone, we use a laser to break down the obstruction and get the files down. Again, we charge $225 for that as well. So no matter what we're getting paid for, whichever dental plan you're on, okay, we discuss using laser. If they don't want to do it, then we say, our option would be is we might have to refer you out. And then if they go to the endodontist, they're going to be charged like 10 times as much. So at this point in time, they're usually pretty successful. But explain the differences, why it's happening. We're removing more bacteria, and your dental plan doesn't allow us to do that with their fees, so we have to change. All right. So prosthodontics, I mean, if you're not using it for crown and veneer removal, I mean, it's certainly worth a shot. Veneer removal is by far more successful than crown removal, but crown removal is, 60 to 70% successful. In this case here, you're moving slowly to break down the layer of cement, which is through the porcelain and zirconia that you have. You have to move fairly slowly. They're working at much higher power at this stage. They're working at about 5 or 6 watts. So the energy is being forced very heavily and quickly through the process. Then you have to cover 360 around the whole tooth, and then finish on the occlusal surface. Once you've done that, grab one of your tools. I love this tool here. Just grab on it like this. And off it comes. As you can see, it looks a little black in there. That's just some of the heat being generated to help break down the bond, and that's easily polished in. But it doesn't cause any damage to it. We already showed the veneers, so I'm going to skip that when I'm watching my time. But then we also can use this for troughing. This is what it should look like after you're done troughing. No bleeding. 100% seeing your margin. You'll be able to, again, reset your margin much better because you'll be able to see it better. There's no cord in your way, and your scans are much clearer. So your lab technicians, or if you're doing it in-house, your assistant who does your lab tech, or you yourself can find your margins much better at that point, because that's what you want to see. And then in a case like this, is a full mouth, what I did, so I can see all my margins very quickly and easily. And I can scan this all at once, and I don't have to do a couple of teeth at a time. So again, my scanning is faster as well. It's just about like scanning a study mode. All right. And then you have options like this one here. I mean, you have a failing margin. Again, I would charge 2 procedures for this, which we can now. The 4212 is, again, removing tissue. There's no bleeding. Now I'm working my way under the crown. Laser energy has an affinity to remove infected tissue first, so it's going to remove decay, so then I can probe. I'm doing that in H mode. And now I'm onto the tissue. I'm going to recontour the tissue just enough so I can set my gingival margin. No cord, no retraction of any point, not necessary. And this procedure there, it would take you 5 to 10 minutes of chair time. So we're just getting rid of bottom. So there we go. So crown and veneer removal. Okay, if we are working in situations where I've had people come over and say, "Hey, I need my veneers taken off from another doctor," I might charge them about $150 a unit if they're simple. If they're a little bit more difficult, I might charge them $250. Access to restorations, that's a procedure code that's available to us now in a 4212. Again, we can do that. Troughing, again, there's a fee for that if you want to charge for that. If it's a gingivectomy, if it's taking a long time and you have to spend a lot of time doing that, we charge for that as well. Crown lengthening, osseous, again, that is a procedure that you can do as well. I'm not going to get into the procedure itself too much, but again, another procedure to charge out for. There's a code for that as well. Managed from there. Laser assisted extractions. Again, we can use the laser. I'll bring up one video here to show you how we move that laser around the whole tooth that's there. In this case here, we're breaking down the tissue. We're moving right down as deep as we can down to the bone with the tip. And we're going to drop around 360 degrees all the way around the tooth, make a few swipes. You can see I'm working at about 4 watts, and I'm working at about 10 hertz to 30 hertz in H mode to do this. I'm keeping the water turned up to about 90% because that's what you want to do, because you're going deep into the tissue and you don't want to cause any burning of the tissue. As you're working, a bit of if you're noticing, I have my high volume close. I'll only do that for pictures. Some of you heard me talk before. I usually tell you to keep the saliva ejector close to the surgical site because you don't want to suck that water away. So now we've kind of opened up that area, troughed it, reduced some of the PDL that's opening up, and it makes the extraction so much more easy. Let me just pop it out there. So again, extractions is useful. I'm watching my time here. So we, after an extraction, we can, if we feel like there is some infection in that zone, we are going to go with socket debridement with the laser. We're going to use either a radial firing tip at that point in time. And the same thing, we're doing the same idea when we're placing an implant. In part of our procedure, I'm throwing out a fee for you, but it's kind of all encompassing in our placement fee, is that we are cleaning out the osteotomy prior to torquing the implant in. We're sterilizing it, stimulating blood flow, and also stimulating osteoblasts, so we get a quicker integration. And we use a laser for extractions when we do it, which is generally all the time. Once you've done it once or twice, you'll go, oh my goodness gracious, why don't I do this on everything? And we just charge for our laser fee as well. Okay, so here's the crown lengthening again. That's the 49, 42, 49. Measure it, and it takes about 10 minutes of time as well. All right. We talked about that one. And just getting into quickly to restorative. And restorative again, pick and choose your cases. I mean, if you're not doing incisal edge repair, or you have been doing it with a burr, now you can do this quicker, faster, and the end result is it will stay in position and it will not fall out compared to using it with a burr. And again, moving slowly, watching what happens to the tissue that you're aiming the laser at, and not trying to poke away at it too much. Cleaning out and troughing some of the dentin away. You're keeping the enamel. What's better? When you do that, the bond is always better on enamel. So it works quite well. All right, so what are we doing? We're removing the smear layer. We're laser etching. It stimulates reparative dentin, reduces sensitivity because it's bactericidal. It improves your bond strength by at least 50%. It reduces micro leakage. So even if you remove the restoration with the burr, finish with the laser at that point. All right. And at that point in time, you don't have to use phosphoric acid or glue. All right. So when Melinda did a study, they managed to did a burr cut and they did a laser cut. And they found that the laser cut was a 50% increase in bond strength. This study's been out for many, many years at that stage. And then soft tissue procedures, I'm not going to show you too many of them, but if you're not doing frenectomies, you should. If you're scared to do them, get some more training. Guided tissue regeneration, you can do that instead of grafting. There's fibroma excisions and removal of hyperplastic tissue. Again, there's a codes available for it, and you have the best tool to have that done. One that's not coded out is removal of pigmentation from the gingival tissues on some of our African American type patients. And we could remove it with the water lays by just stripping off the staining of the tissue, which is just in the surface epithelium laser, and this with 1 day post-op. You can do this procedure very quickly and easily with a strong topical anesthesia as well. Okay, so now to wind up here, as we're looking at time, life is full of important choices. I understand that. I would never go to the tee box with my putter Generally, it's with my driver or a low iron. So beauty also is we have the ADA came out in 2026. These are two codes that are used for photobiomodulation therapy that is used in the that now we have that ability now in seeing that the ADA is starting to recognize the benefits of laser therapy. So now, hopefully, as time goes on, we will start having some more of this coded. But does it matter if it's coded? Will insurance plans pick it up? Probably not, right? Nothing was more frustrating when I listened to something the other day, and our CEO of Delta is his annual salary is $42 million, and here we are doing $40 fillings for Delta. How fair is that? I'm telling you, some of these things just drive you crazy. Anyhow, no matter how many mistakes you make, you're still about ahead of anybody who isn't trying. I think Tony is a great person that and telling and stimulating people. If you start including LAPT, maybe a crown lengthening once or twice a month, one or two frenectomies, some troughing, maybe a biopsy, do some incisal wear restorations on the anterior zone and the up here, you're going to see an extra $6,000 to $7,500 increase in your practice just from those 6 procedures. And if you're not doing them, why aren't you? If it's because of lack of knowledge, then guess what? You got 2 choices. Okay. Megagen, who is now the owner of BioLays, we run a foundations course. I think there's a foundations course just about every quarter somewhere in the country. All right, that's an option. Okay, that can be done, and it's we have various. I mean, I teach them in Orange County. Somebody else teaches them in Texas, and I think there's another one in New Jersey. All right, in office training. Well, that is me as a clinician coming to you to go over how things done, and then from there you book patients. We're not working on a pig jaw. We're actually working on real people. All right. And we're billing for real procedures. All right. So when I come to your practices to do something like that, what we bill for basically pays for me to come to your practice that day. All right. So you're not losing time out of the office, which is a great way to possibly do things, especially if you've had it and you're working with it for a while and you want to manage from there. All right. So that's how you get a hold of me. And I have a small little company called Dental Technology Institute. You can reach out to me for any questions and that sort of thing, or send me an email. I'll be more than glad to help you out in that respect, that sort of thing. If you want to do that, you can also grab a picture of this QR code, and that'll take you to it as well. All right. Thank you very much for listening. I hope that I've answered some of your questions. I didn't see too much come up in the chat bot, but if you have any questions, go ahead. We'll give you about 4 or 5 minutes. And there's no, if you don't worry about the question, I'll answer it. And I promise you, I won't laugh at any question.
Yeah, no questions so far, Dr. Brad. Thank you very much for the presentation. Great webinar as always. We do have a few minutes for Dr. Brad. If anybody has any questions, you can put them on the chat box. I'll be glad to read it out for you. Other than that, I hope everyone has a great and fantastic Wednesday and a great rest of the week.
Right on.
We'll give it just a minute here.
Yep, no problem.
If anybody,
I'll leave that up there.
is there a recording that we can watch? Yes, absolutely. Dr. Sharma, I can absolutely send you the webinar lecture. Not a problem. Yes, no problem, Dr. Sharma. I can do that for you. Any other questions? Yes, Dr. Dan. Sorry, I don't think I can pronounce your last name without messing it up. Dr. Larson, you'll be receiving a questionnaire tomorrow, 5 questions, and then you'll be receiving your CE. We do have one question from Dr. Scarlett. Dr. Brad, what tip do you use for hemangioma? I'm really messing this one up.
Hemangioma?
Hemangioma? Hemangioma, yes.
Hemangioma. So when you're doing a hemangioma, we're working, there's various powers that you have to do depending on how big it is and managing it from that way. Generally, you in the smaller ones, you can just get some desensitization with some ice as opposed to doing an injection. And I use just the 400 micron tip at that point in time. All right, to get to aim at it, and you move slowly over the lesion to get coagulation.
All right, thank you for that. Yes, Dr. Lobel, I'll also send you the recording as well. No problem. From Dr. Fred Luongo, what tip setting for crown removal?
Well, crown removal is asking for tips. The tip that I use is an MZ6 tip.
That's usually the workhorse tip, right?
Yeah.
The MZ6.
And then based from there, I'm running it around 10 to 15 hertz, and I'm running it around 4 to 5 watts.
Perfect. That was the second question. You answered it.
All good.
All right. That gives us just about all the time for Dr. Brad. Thank you very much again. You have all his information. If you have any questions for him, please, you have his email. And if you do not, you can always reach out to me. My name is Javier Gutierrez. I'm the one who sent you the link earlier this morning and yesterday, just to make sure you guys can jump on. So um, if you can't get a hold of Dr. Brad Labrecque, you can get a hold of me. Uh, yes. More with the recordings. Absolutely. I will definitely do that. I'll put it this way. I'll send it to everyone that was on this webinar lecture. So no worries there.
All right.
All
Well,
right. Thank you as
scan
well.
that QR code.
There you go. Dr. Brett, thank you so much for everything. Thank you for your time. Thank you everyone for joining us. It was a pleasure. Look forward to some more webinars ahead. There's lots more trainings. Please go to biolace.com on the education tab if you want to brush up on some techniques in your diode, in your water lace, or if you have any other questions, please reach out to me. I'll be glad to help you out. Everyone have a fantastic evening.
Happy dentistry to everybody. Have a great day.